tell you a little bit about what's been going on. Here we go. Yeah, I'll talk about 5 slides too quickly there. So if we just go back, that's my disclosures. So the issue we're dealing with here is really driven by this worldwide epidemic of obesity. And of course we tend to associate being overweight, it's really a North American problem, or maybe a Western European problem, but in fact it's affecting every population in the world. So even countries like India, which you might imagine would be relatively protected, as you can see here, are coming up with an order of between 35 and 50% of the population being clinically overweight or obese. So this is genuinely an international challenge. And it's really due to differences in our lifestyle in terms of more sedentary occupations and also easier access to high-calorie food. And here we are in the UK, in the northeast. You can see that, again, we're one of the most highly affected areas of the UK for high body mass index, in other words, being overweight or obese. But when we talk about this, there's an assumption that we're always talking about people at the extremes of being overweight. And what I want to point out to you is that that's really not the issue here. And this is a key graph, and I think one of the most important things that I'm going to show you today. So this is basically the distribution of body mass indexes. We know that we're aiming for a body mass index of somewhere between 20 and 25, which is what we call normal. But the reality is that over the last 10 to 20 years, there's been this shift to the right-hand side of the whole curve. So we've got this normal distribution, and if we look at the dotted line, maybe the red dotted line here, we can see that that's now moved this way into the red straight line. And so that means that we're not just talking about a condition where people at the extremes, the sort of people we see on the front of the tabloid newspapers, are being affected by fatty liver. It's affecting us all. The man in the street, or the woman in the street, is 1 or 2 pounds heavier now than they were 10 years ago. And this is the challenge we're faced with, is the fact that we're all carrying a little bit more weight than the generation before us did. And with that, fat is accumulating in the liver and driving the problems we're going to talk about today. So as I go through the talk today, I'll probably talk about being overweight or obese, but what I'm really talking about is carrying more weight than we should be carrying, whatever that may be. So we know about the medical consequences of being overweight. There's a greater risk of having diabetes, a greater risk of high cholesterol, what's called dyslipidemia, and a greater risk of high blood pressure. And then, of course, there are all the peripheral problems that can be associated with it. More likely to have strokes, problems like cataracts, heart problems, kidney problems. There's an increased risk of cancer, not just in the liver, but in most organs in the body. And then non-alcoholic fatty liver disease, which is really the hepatologists trying to get in on the act. And so here we can see the general medical consequences of being overweight or obese. And the one which is closest to my heart is, of course, this non-alcoholic fatty liver disease, essentially defined as being the accumulation of fat in the liver, more than 5% of the liver being fat, obviously in a background of not consuming high amounts of alcohol. And I know that this is something that frustrates an awful lot of the patients, that they feel that being told that there's a problem with the liver might imply an alcohol problem. Of course, in this room we all know that that's complete rubbish, and there are many reasons why this can happen. And in this case, this is being driven by being overweight or having diabetes. And there are a number of steps in the process. So we start off, as I've said, with steatosis. That's just fat accumulation in the liver. We then move on to steatohepatitis, which is fat and inflammation. And then from that, we can move up with scarring or fibrosis. And in a small number of individuals, this can progress on to hepatocellular carcinoma, so liver cancer. And this is really the spectrum of disease that we talk about when we talk about non-alcoholic fatty liver disease. And within that condition, you can be anywhere on that spectrum. So one of the challenges that I'm faced with is trying to decide where somebody sits on that spectrum of disease. Because, of course, that's going to determine to a certain extent how we best look after people. So, how common is fatty liver? John has suggested that this is the coming plague. I think that's a little bit dramatic,
epidemic,
but it's certainly a problem, and it's one that's on the rise. Now, You get a slightly different idea of how many people have fatty liver disease, depending on which country in the world you go to, and depending on how you look. The ideal way for us would be we would go off to the metro centre with a Mangini needle and we biopsy everybody who walks through the door. Clearly that wouldn't be very popular, and I'm certainly not advocating it. But when you look by scans, we can see that somewhere in the order of between about 20 and 30% of the population in the majority of countries where people have looked will have some degree of non-alcoholic fatty liver disease. So they'll be somewhere on that spectrum from just a little bit of fat in the liver all the way down to cirrhosis and beyond. And that's a fairly good guide to it. We can give a little bit more detail than that. So this is a study from Italy. And what they did was they took a population living in northern Italy, and they found that about 94% of individuals who were clinically obese, that's with a BMI of greater than 30, had fatty liver disease. They found that about 2/3 of people who are overweight, body mass index of 25, will have non-alcoholic fatty liver disease. And about 1/4 of people who are in the healthy weight bracket, between 20 and 25, also had fat accumulation in the liver. And this goes back to that shift I was talking about with that curve, because we're all different. And so each one of us has, I think what's best to consider it as a personal fat threshold. And none of us know what our fat threshold is, but there's a line somewhere, and when we cross it, fat begins to accumulate in the liver. And that's why people who you might see badged as normal weight may have fat in their liver, just in the same way as people who might be easier to spot as being overweight or obese may have fat in the liver. And so again, just the bathroom scales, they give us a guide to be sure, but that's not the whole question. So this idea of a personal fat threshold is very important. And I think it's also something to keep back in our minds when we talk about the next challenge, which is how do we spot the people who are going to stay with just a little bit of fat in the liver, and how do we spot the people who are going to go beyond that to cirrhosis and so on. Is fatty liver disease a problem? Does it actually matter having a little bit of fat in the liver? There are many people out there, doctors as well, who would say probably not. I tend to disagree with that. This is quite an old study now from 2011, where they've looked at a number of the studies that have been published and looked at outcomes. And what it's telling us here is that people with non-alcoholic fatty liver disease have approximately a 50% increased risk of death within a given period of time compared with age and sex-matched controls in that population. So this is a serious condition. It doesn't mean that people are all going to pass away with liver disease, but it does imply a greater risk of heart attacks, strokes, liver disease and so on. So it's a common condition, about 20 to 30% of the population, and there is an increased risk with it. Now that does, of course, and I must stress this, particularly for this audience, does not mean that everybody with fatty liver disease is going to have a problem. So we need to keep it in perspective that there is an increase in associated risk that comes with this condition. Okay? And backing that up, this is some data from North America, from Ohio, where we can see that fatty liver disease is rapidly increasing as the indication, the principal indication for liver transplantation. What we can also see here is that alcohol, which is this line here, and viral hepatitis, which is this line here, are both coming down. Now this is due to a number of different factors. There are better treatments for viral hepatitis now. The antivirals have moved on dramatically in the last few years. So we're more effective at clearing the virus, and so we would hope and expect that over the next few years, less and less people with hepatitis C require a transplant because the virus is gone. But it's also a function of the fact that in every population that has been looked at, fatty liver disease is becoming more prevalent, becoming more common as a result of the fact that we're all carrying a few more pounds than we used to. Okay? And that, obviously the data there goes to 2012, but if you take a ruler and extrapolate from them, it's somewhere in the next 5 or 6 years that those lines cross over. Now, time will tell. You can change those lines very easily if the government doesn't pay for antiviral treatment, the hepatitis C line will stop falling, and so on. So, but that's the prediction here, that within the next 5 to 10 years, non-alcoholic fatty liver disease will become the most common indication for liver transplantation. And really backing that up, and this is data produced from Newcastle from my colleague Helen Reeves, and many of you will have seen this data before. What we're also seeing here is that in terms of HCC, in terms of liver cancer, the proportion of individuals where when we look back and try to work out why they've got it, what the underlying cause for this may have been, the proportion of individuals where this turns out to be non-alcoholic fatty liver disease has been increasing year on year. And that's the orange bar here, which we can see has been steadily increasing over that time. So, fatty liver disease, it increases the risk of cardiovascular problems, it increases the risk of progression to cirrhosis, it increases the risk of liver cancer, and the readout of that is the fact that more and more people are requiring liver transplant to fix this problem. So, clearly, there's some important things here. But there are some challenges as well. And I just wanted to go through some of the challenges we're faced with. First of all, as I've said to you, there's this high disease prevalence. There's a lot of it about, but there's a low awareness of the condition, both in the general public and also, sadly, amongst the medical profession. So that means that the majority of people with fatty liver disease have not been detected yet, have not been diagnosed with this condition. We also know that there's limited data on the disease natural history, by which I mean how the disease progresses, outside a few highly selected cohorts from specialist centres, such as here at the Freeman. And unfortunately, that means that policymakers are left in a rather difficult position, because they say, well, show me the facts, and I'll fix it. But until we can get them the facts, they won't listen. So we're working on that one, and I'll show you some of the data that's helping with that. And now the next thing, this is a key thing, and it comes back, there's this high interpatient variability in outcomes. So I've said that it can progress to all those problems, but it's worth remembering that the vast majority of people with non-alcoholic fatty liver disease will never be ill from it, not one day in their lives. Okay? So it's a very common condition, which means that there will be a large number of people who do progress, but as one individual with NAFLD, the chances of you in particular having a problem is more modest. Not negligible, but more modest. And that's a key point. And so we need ways of working out who are the people who are going to have the problem so we can focus care on them. And that really feeds into this one. There are no good non-invasive tests, or at least there haven't been. And that's why, up until now, we've been really quite reliant on liver biopsy, which I appreciate is not the most popular test in the world, in order to diagnose the condition. And finally, there have been no licensed medicines for the treatment of fatty liver disease. And until recently, frankly, pharma, in other words, the drug companies, haven't been very interested in this condition. But that's changing, and that's very exciting development, because it means for the first time we're getting valid drugs coming into trial which are showing promising results, and that's going to change the whole situation, I suspect. And so, of course, at the moment, most of the treatment of what I'm going to talk about today mainly will be focusing on lifestyle change, and it feeds into the first point, this low awareness of the condition, because there's a slightly nihilistic view amongst some doctors, which is, if you haven't got a treatment for it, what's the point of finding it? And you can sort of see why people might think that. I disagree with it, but you can understand the flawed logic behind it. So what are the recent advances? Well, I'm pleased to say that we've now got a better understanding of how the disease progresses, and this is really data that's come out in the last 1 or 2 years, so that's very exciting. Both in terms of how the disease goes, and also some of the factors that help us work out who's at greatest risk of progression. We've got some improvements in diagnostic testing as well, and there's an improvement in the therapeutics. Much of it is still in trial, so I can't be prescribing any of these medicines yet, but we are moving to a time where I think there are some really valid candidates out there. And certainly when I was last here 5 years ago, that wasn't a statement I could make to this room, so I'm quite pleased to be able to say that to you. So, what about rates of progression? Well, this is the classic view of fatty liver disease, and it pretty much feeds into those things. We start with a normal liver, we move on to steatosis, which is just fat accumulation. When I see people in the clinic, I tend to say about 1 in 10 people move from there to there, and about 1 in 10 people move from there to there. And that's a reasonable assessment. And probably slightly fewer than 1 in 10 go all the way to cirrhosis, but a reasonable assessment is about a 1 in 100 will have some degree of significant scarring of the liver. But what we're finding now is that we need to rethink that slightly. It's not quite this linear, this straight pattern that we've previously talked about with fatty liver disease. The first thing I'd like to point out is that we now appreciate that this first step, this movement from steatosis to NASH, is much more dynamic than it was. It's not a plunk, 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 you're there. You're moving back and forth all the time. So I like to think of it almost like planets orbiting, and sometimes you're a bit nearer the sun, it's summer, or you're in NASH, and sometimes you're a bit further away, it's winter, and things are more like steatosis. And so this is what's happening in our livers all the time. We're cycling through just fat in the liver and maybe a bit of inflammation. And the reason why that's important is because there has been a reliance on the liver biopsy. We found steatosis and we said, don't worry about it, everything's going to be all right. But what we're now appreciating is that it comes down slightly to the time when we actually take the biopsy. So if we happen to take the biopsy at the point you're orbiting in winter through steatosis, we'll catch steatosis. But if we come back this way, we might catch you in the summer. So there can be that variation in terms of the inflammation in the liver by the timing, and that causes some sampling error. I suspect what happens is, though, that there are some of us who spend more time towards the left-hand side of that in winter, and there are some of us who spend more time in the inflammatory side of that. So it's not a completely useless test from picking up steatosis to steatohepatitis, but it does mean we can't rely on it completely. And then fibrosis, and this is the next thing. What we're seeing here is that there tend to be two types of people with fibrosis. The vast majority of people get a slow progression of fibrosis, which may take 5, 6, 7 years, maybe even longer, just to get really quite mild fibrosis. And the majority of those individuals will probably stay at that, and they're probably all right, to be honest with you, because you can tolerate a bit of scarring of the liver without too much of a problem. But there'll be this other group, a smaller group, who will develop a more rapid form of progression and go down towards advanced fibrosis and cirrhosis more quickly. And so we're beginning to rethink from that sort of nice linear thing that we've all travelled down in, we're beginning to understand that there's much more variation in this than there had previously been. And this is just some of the data, and I apologise if this graph is a little bit heavy and a bit boring, to be honest with you. But what we're seeing here, this is a very nice study from Sweden, actually. 230 patients with biopsy-proven fatty liver disease. And what they found was when they followed people out for 26, 27 years, up to 33 years, they found that the best predictor of survival was how much scarring there was in the liver. Not how much inflammation there was in the liver in the biopsy, but how much scarring. And so we really need to focus on the scarring aspect of this as a key predictor. So that's the first type of data that's helped us rethink the natural history of fatty liver disease. The second type of data, and this is data from Newcastle, is the dual biopsy studies. Now, we're very fortunate here because obviously at the Freeman there's been a great interest in fatty liver disease going back 10, 20 years and beyond, and over that time very good records have been kept of people, and so a number of people have had more than one liver biopsy over that time. Now that's a very precious resource because we've been able to actually go back and look at those old biopsies and work out what was it like at the first biopsy, what was it like at the second biopsy, and what were the factors that might have predicted. If I'd known something on the first biopsy, what could have told me about the future when I looked back then? Okay. And this data was quite interesting. So 108 cases, it doesn't sound like a huge number, but that's the biggest cohort of patients who've gone through more than one liver biopsy in the world. So what we found here was that, as I said, we'd always thought that steatosis was fine and you got steatosis and you didn't need to worry about it too much, whereas NASH was the bad boy. But what we found is that if we looked overall, we found that over a median of 6 or 7 years, about 40% of people got more scarring, about 40% stayed the same, and about 20% got a little bit better. What we also found was when we looked at the individuals who just had steatosis, just what we thought previously was a pretty benign condition, we were seeing about the same thing. About 40% of them actually wound up with NASH later on. About 40% had progressed, so got more fibrosis, and some of them had even gone all the way through, not quite to cirrhosis, but one before it, the yellow card before cirrhosis. So we're seeing here, and this feeds in, this is really where this idea of that variability in the sun and the moon that I was talking about before, that's where that comes from. And it's based on this data, showing that actually things are much more dynamic than we thought they had been. And what was the key factor which predicted individuals more likely to progress? And it was whether people developed diabetes in the interim. That was the single strongest predictor of disease progression in our study. So, there we are. That's how we got to this as our current model. But there's more to it than that, because as I've said to you, there's still an awful lot of variation here, isn't there? We're going back and forth, we're swirling around on the left. Some people go very slowly, some people go faster. So this is, of course, where the genes and the environment come in. This is the lifestyle choices and things intrinsic to us. So fatty liver is best considered what's called a complex disease trait. Some of it we can't do anything about. We can't change our genes. Some of it, however, is our environment. Now, that may be deliberate things. It may be nothing to do with deliberate actions. Some of it can be, for example, the very bacteria that live in our bowel can be contributing to this. But all of these come together to give you a specific disease phenotype, to determine, to make us what we are, if you like. What do we know about environmental factors? Well, we're getting some ideas. Diets that are low in antioxidants tend to have more aggressive disease. Total or saturated fat, high levels of that in your diet, it's bad. Fructose, which is a fruit sugar, tends to be bad. There's some data that coffee is protective. Interesting. I've left this one on the slide, although I'll probably get lynched for it. Moderate alcohol consumption is protective. Now, that could be an epidemiological quirk, so I'm certainly not suggesting we all head to the pub after this. But it's quite interesting that it appears that 1 or 2 units of alcohol a week tends to be associated with less aggressive non-alcoholic fatty liver disease. Having obstructive sleep apnea, which is a breathing or a snoring problem, tends to be associated with more aggressive disease. And as I've just mentioned briefly, there's some really exciting new data about the bacteria that live in the bowel and the differences between the bacteria of all of us that may also influence how our disease progresses. The area that interests me, however, is the genetics and trying to understand what it is about each of us that makes us unique and makes us have different possibilities of disease progression without any of these other factors. And one of the greatest advances we've had in the last few years has been this genome-wide association study, where we take a large group of people and we study pretty much all the genetic variation in them in one go. So rather than me thinking of one gene and thinking, oh, I'd like to test that gene out because it might be important, we test the whole lot. So it's like a shotgun approach. And it's a very powerful one. Now, there have been a number of studies looking at this, but the vast majority of them have only looked at steatosis, have only looked at fat inflammation in the liver, and haven't looked at fibrosis. And as I've said to you, it appears that fibrosis is the thing that actually matters. So we've led a study which we did during the previous FLIP project, where we've assembled over 1,000 individuals, not just from Newcastle, but from all over Europe, who've had biopsies for fatty liver disease, so that we can start to look at their genetics. And as we go on, every so often I'll just show you some of the data that hasn't been published from that, just as a bit of fun. So, what's the first gene? Well, the first gene came out a few years ago from an American study. It's this gene PNPLA3. And carriers of an abnormal form of this gene, which are very common. About 1/3 of us in the population carry the variant form of this particular gene. So it's really common. They tend to accumulate more fat in the liver, and they tend to accumulate more scarring in the liver. So that's quite important. And here's the data from our genome-wide association study, which I'll go through very quickly. But again, this dot up here is that variant. And the higher it is, the more important it is, essentially. And what we can see here is that that variant was very strongly associated with progression of fatty liver disease and scarring. So that's quite important. Now, it's not good enough. We can't go off to the clinic and all test each other now and tell the future. It doesn't work like that, unfortunately. All right? But it does give us a strong signal and gives us exciting information in how this disease may be progressing, and gives us information about the biology, what's actually happening in our cells as the disease moves on. The other thing about this particular variant is that it may be associated with the increased risk of liver cancer. So again, here's some of the data again from Newcastle. We looked at that same variant in patients here from Newcastle and actually some from Switzerland who'd got fatty liver disease. And what we found was that carrying this particular variant was associated with about 5 times increased chance of getting liver cancer compared with people who didn't carry it, even when we controlled for age, gender, diabetes, and even having cirrhosis or not. So this was quite a strong predictor. And in fact, when you compare it against some populations, that risk may go up to 12 times higher. That sounds like a big number, but it's worth pointing out to you that for that to be a useful test clinically, that number would have to be 50 times higher. Right? So carrying that variant does not mean that people are going to get liver cancer at all. What it may mean, and this is something we're working on at the moment, is that if you don't carry that variant, the chances of you getting liver cancer are so low that you don't need the 6-monthly ultrasound scans and those sort of things. That's work in progress. We don't know that yet, but it's something we're looking at and could be quite exciting in the future. Okay. Then we move on. Another genome-wide association study came out last year. Found this new gene, TM6SF2. Now we were quite excited about that one. What was found with that original study was, again, if you carry the less common variant, now this one is really much less common, it's present in about 10% of us. Again, more fat in the liver. So we were quite keen to look to find out whether it was also associated with more scarring in the liver. And indeed it was. Round about a 1.5 to 2 times greater risk of developing advanced fibrosis or cirrhosis in people who carry these. So we're beginning to build up this panel of different genes, and each one of them contributes a little bit to our risk and a little bit to our variation. It doesn't answer it all on its own, but it's beginning to explain it. There's something very interesting about this test. There have been lots of genes, so that was our paper. We came in here in 2014, so we were one of the first. Very chuffed about that. But then since then, there have been a number of other studies coming along. And what we found is that we all agree that if you carry that variant form of this gene, you tend to have more fat in your liver and more scarring in the liver. But some of these studies found something interesting. If you carry that variant form that's bad for your liver, that's not good. But if you carry the not variant, the normal form of that disease, when they looked to find out what happened to those people, there was a higher risk of heart attack or stroke. So we get this quite interesting idea here that however you cut it, being overweight or having diabetes probably isn't good for us. I think we can all agree with that. But this gene appears to regulate what happens next. So if we carry the variant form, we'll keep the fat in the liver, and we're at a greater risk of progressing down and getting a liver problem and coming to see me in clinic. But if we carry the other form, it appears that we push the fat out of the liver, have high cholesterol, and are more likely to have a heart attack or a stroke and see the cardiologist at the other end of the freeway. So, quite an interesting idea here. Now, that, you might be a bit dispirited at this point, and you might say, "Oh, that's rubbish. You know, it's bad either way." But what again it's helping us do in the future, we need more work on this again. It's something we're working on. But what it may do is when we've got 30% of the population who are overweight, many of them getting diabetes and so on, these are the sort of tests that help us to work out, do we need to worry about your liver? Do we need to worry about your heart? Which bit should we focus on? Where do we need to put our resources? Because of course the NHS is not as rich as we would like it to be, and so this is a way we might in the future be able to help. A lot of work to be done on this, early days, but quite exciting prospects here. So that brings me on now to the reality. Where are we actually at the moment? And this is the bit that I think all the rest of it before has been very exciting, but it's pie in the sky. This is where we actually are now. And the challenge is, there are an awful lot of us at risk. How do we spot those of us who are actually going to have progressive liver disease? Now, most of you come to the clinic, we tend to measure and talk about calculating this NAFLD fibrosis score. And if you see me, I talk about whether you're in the red or the amber or the green categories and so on. And we sort of talk about where it is. And this is a really useful test. It's free, and that's pretty good. And it's based on pragmatic scores. This is what we calculate to give us an idea of what the likelihood of having significant scarring of the liver is. It's not bad. It's not brilliant at saying, yes, for sure you do have scarring of the liver, so we're still reliant on biopsy or other tests. But what it's great at is saying, no, you don't have scarring of the liver. And that's very important, because again, 30% of the population have got fatty liver disease. For me, and for all of us actually, what's reassuring is to be able to say to somebody, you don't have advanced liver disease. Go home, don't worry about this. So that's a very useful test for us. And what's even more important is it gives us an idea of the future as well. It doesn't just tell us about how much scarring is in the liver at this moment in time. It helps us to predict individuals who are more likely to run into problems in the future or may even die as a result of their liver disease. So a useful test here, and based on pragmatic, clinically relevant things. Another test that we use quite freely is the FibroScan, and many of you will be familiar with this technique, which measures the stiffness of the liver to give us another idea of scarring. And so this is, when you see us, and I don't know how well we explain it in the clinic sometimes, I fear I don't explain it well enough, but this is the sort of algorithm we're actually going through in our minds when we're doing it. So the first step here, suspected NAFLD, that's recognising the risk. And what we know is that the more features of what's called the metabolic syndrome an individual has, the more likely they are to have fatty liver. And when I say the metabolic syndrome, I mean being overweight, diabetes, high blood pressure, high cholesterol. You can almost count them off on your fingers. The more of those somebody has, the more likely they are to have fatty liver. What we then do, when you see us, is we calculate that NAFLD fibrosis score. That's something that could be done by the GPs, and it's something that we're beginning to increase. We're talking to our colleagues about, so that more and more of that is actually being done in general practice rather than you having to come to see a specialist for it. And that gives us good information. Again, red, amber, green. So red, amber, green. If you're in the amber or the red categories, we'd suggest that need to be seen in a clinic, so refer to secondary care. But of course, if you're in the green, because this test has what's called a very high negative predictive value, which means if you're in the green category, we can be really very comfortable with the idea there's nothing bad happening in your liver at the moment. That means that a lot of people can be reassured correctly and allowed to stay with the GP. Okay. The next stage here is, this is where we bring in the FibroScan. So we can't FibroScan everybody, third of the UK, so we can use the first test to help us. The second test begins to narrow it down further. And it means we reserve liver biopsy for an ever smaller group of people. So we avoid using liver biopsy as much as possible. Not because it's terrible, many of you in this room will have had a liver biopsy. It's not the nicest thing, I'm not going to kid you, we all know that, but it's not the worst thing that's ever happened either. And so that's really what the algorithm is. And it gives us some ideas as to how we can look after people with fatty liver disease. If it's low risk, the main things here are lifestyle advice, reduce the chance of having a heart attack or stroke, and then monitor. So what we tend to say if we discharge people from the clinic is, I'd like to see you again in 5 years' time, and if you were to become diabetic, we'd like to see you then as well. And that's based on the data I've shown you with our dual biopsy studies, the reasons why we say that. People who come up in the medium or the high-risk categories, obviously the treatment is more tailored to the individual, and we're very lucky here in Newcastle that in our fatty liver clinic we have a dietitian on hand, we have an exercise physiologist, and many of you have met members of the team who I'm lucky enough to work with. And that's how we can really focus the care on the people who've got the most to benefit from it. So what are the principles of treatment? Well, 4 steps. Number 1, control obesity. Let's get the weight down. Number 2, we need to treat the metabolic syndrome. Remember, as I've said to you, only a minority of people with fatty liver disease will ever suffer a liver-related event. More of them will have heart attacks or strokes. And so it's very important that we look after people, get their cholesterol down, get their blood pressure well controlled, get their diabetes well controlled. Then we want to prevent progression if we can. We want to prevent development of cancer. So, lifestyle change. This is the single most important. It's the best thing we've got at the moment. We're not looking to convert everyone into Kate Moss thin supermodels. We're looking to get about 7 to 9% of our weight off. The evidence is that that's all it takes if we can sustain it to pull the fat out of the liver and stop the progression of this disease. But often people lack the confidence to make these changes. It's quite difficult, you know, particularly, I don't know about you, I don't go to the gym as often as I'd like to. I really very seldom go. I know that'll surprise you all. But I don't know about you, but sometimes you lack confidence to go and do these things. You know, the last thing I want to do is go to the gym and find some sort of 21-year-old bloke charging around on a treadmill beside me, making me look bad and wheeze. So, you know, it gets competitive. So people are often quite reluctant to do this. This is an area where we need to help. And we're very grateful to LIVErNORTH for helping us with produced this booklet, Lifestyle in Your Liver, which it's a guide to fatty liver, and I hope that it's something that gives some useful advice, gives a little bit of background on what we're talking about with fatty liver disease, talks a little bit about how to look after the liver, this idea of how to manage weight loss and so on, changes in the diet. We're very keen on the Mediterranean diet at the moment. It's quite a healthy diet, there's a lot of benefits with it. Also some stuff about changing exercise. It isn't going to the gym, it's walking a little bit more, it's getting off the bus one stop sooner, things along those lines. And some fun tables so you can track your own progress. So I do recommend the book to you, but equally we'd be very interested in having feedback. We spend a lot of time on it. It can always be improved, and we're looking for that, so do let us know. But what are the management priorities beyond the lifestyle advice that we've talked about? Well, as I said, we need to control the metabolic syndrome, get rid of that diabetes, that hypertension, that high cholesterol. All of those reduce the chance of heart attacks and strokes, so that's key to this. The next thing we need to do is, if possible, slow the progression of fibrosis. Now, this is going to be the corner of the pie chart that improves most in the next few years, I expect. At the moment, we haven't got a single medicine licensed to treat non-alcoholic fatty liver disease. But what we have got is knowledge that there are certain medicines out there that may have an additional benefit. They're not designed for your liver, but they may have a benefit for your liver. So losartan is a blood pressure tablet. There's some evidence that it reduces or slows down scarring on the liver. Some of you in the room may have taken part in the Feline Study that was run here from Newcastle. That was randomising people to losartan or a tic-tac, a placebo, to see if losartan did actually work. We haven't seen the data on that final study yet, but the preliminary data that allowed us to go forward with that study was very promising. So losartan is useful. There are certain medicines for treating the diabetes that, again, may have an additional beneficial effect on stopping fibrosis. So we try to move people onto those medicines. And then we talked about reducing the risk of developing liver cancer. One of the drugs I think is most interesting here is Metformin, a good old friend of ours used for treating diabetes. If you read the packet, it says don't give it to people with liver disease. But for every year individuals take Metformin, the risk of developing liver cancer reduces by 7%. So, hence, I'm a fan. Okay? Doesn't mean it will prevent it 100%, but that's a pretty good cumulative benefit over 5 or 10 years' use. What about the future? What's on the horizon? Well, there have been loads of trials going on recently. And a number of these are going to be reporting quite shortly. The Flynn Study, the top one there, I'll show you one slide on that one because the data has been published. Again, some people here in Newcastle took part in Golden 505, GFT 505. This was another new medicine. The preliminary data for that one also very promising. So both those top two, Flint and Golden 505, which are new medicines, have provided encouraging data, with the top one having actually been published and the other one hopefully coming out shortly. Liraglutide, a medicine for treating diabetes. That was a study run actually in Birmingham. Again, promising data. Although whether the medicine did any more than help people lose weight, it's difficult to say at this point. But again, evidence is it reduced inflammation in the liver and may have reduced fibrosis. So we've got one drug that we can use at the moment, liraglutide, 2 drugs that are coming around in trial, and both of those are going to come around for a second round of trials, bigger studies, which will be probably opening up later this year and early next year. So an exciting time for fatty liver disease because we've got some medicines here. That's the data on the top one. Quite interesting. So in this study, which was run solely in North America, use of this drug for 72 weeks. It's the same drug that many of you who have PBC may be aware of, because there have been trials running with this agent in primary biliary cirrhosis. But in fatty liver, it was shown to reduce the amount of fat in the liver, reduce the grade of steatohepatitis, and potentially improve scarring of the liver as well. So that was good. Was it the perfect tablet? Not quite. It did alter your cholesterol. So normally HDL is the good cholesterol, LDL is the bad cholesterol. It did swap the ratio of the rows around a little bit, which is less favourable. And so going forward, I suspect that trials will be adding in a statin on top to fix that problem. Okay? But nevertheless, very promising. That's the first published study of a new medicine, I think I'm fair in saying this, which has been quite so good as that. Okay, so not perfect, but promising. And more work, again, needs to be done. So, in the last few seconds, I just want to talk very quickly about EPOS. This is a large European Union-funded research project that's being led here in Newcastle, but is actually involving centres from... Oh, that wasn't good. Is involving centres throughout Europe. Let's see if we can find the wheel there. Yep. And what this study aims to do is to understand a little bit about the factors we talked about. So I've talked about how our diet and the bacteria in our bowel may influence it. I've talked about our genes and how they do. And at the moment, all of that data is, we've looked at one person, we've looked at their genes. We have one group of people who've looked at their genes. We've looked at another group of people who've looked at their diet. We've looked at another group of people who've looked at their bowel and the bacteria. But nobody's put it all together. And so we're guessing that all these things work in a particular way. So what EPOS is going to do is take a very large group of people from all across Europe and collect blood samples from them. And if they're having a liver biopsy, ask for any leftover bits to have a look at. And what we're hoping to do is do all of this analysis on the same people. So these are going to be, frankly, some of the most highly characterised humans in the history of mankind. So we're going to have this large cohort of people. We've already got samples from over 1,000 people. Many of you here may have taken part in the FLIP study and contributed when you were having a liver biopsy into FLIP or the Newcastle Biobank. So those samples you very kindly gave consent will be available for this study. And we'll be looking at the full genome-wide association study of all the variation. We're going to look in the little leftover bits of liver tissue and look at the gene expression of every single gene, which go up, which go down, which stay the same. We're going to look at the blood to look at the cholesterol levels, the sugar levels, and how they alter, not just the standard cholesterol that I measure or the GP measures, but in real detail the different types of fat that are circulating in the blood. And we're going to look in the bowel of the bacteria and see what the differences are. And the hope is, with some very big computers, which is what this section here is about, we're going to be able to look at that in 3 dimensions and twist it round, look so that we can actually finally understand what's going on in the liver and how it is as a whole person and what's going on at the liver and what's going on at the cell level within the liver. It's going to be very exciting, I think. So that's the next 5 or 6 years, which will keep me quiet. And so really, it just leaves me to thank everybody who I work with, Chris Day, Stuart, Tim, Laura, David, Elspeth, and to thank you all very much for your attention, and I hope I haven't gone on too long. Thanks very much indeed.
Any questions, anyone? Here we go.
Now it comes.
Right. Okay, now, what it is, I'm quite worried, right? I diagnosed with type 2 diabetes in the late 70s, I wasn't even 20 then, right? But you saying that, what was that, fatty liver disease, that caused type 2 diabetes, right? But after 20 years, when I had a stroke I was 41 when I had a stroke, and when I was recovering from stroke, they find out I had a Hep C, right? So does diabetes bring that, or did fatty livers brought that diabetes and stroke and heart? So
you've asked a brilliant question. You've asked an absolutely brilliant question, and the answer is, yet again, sadly, it's more complicated than we'd hoped. So we know that people with diabetes are more likely to have fatty liver disease. If we took 100 people with diabetes, type 2 diabetes, somewhere between 40 and 70% of them will have non-alcoholic fatty liver disease. We also know, however, that if we take people with fatty liver disease, not all of them will have diabetes, but if we follow them up, many more of them over the next 5 or 10 years will develop diabetes than if we took 100 people without fatty liver disease and followed them up. So again, it's a chicken and egg thing. But the bottom line to all this is something called insulin resistance. So as we gain weight, our body becomes more insulin resistant. Now there's a sudden tipping point in that insulin resistance where we go from insulin resistant but not diabetic, and insulin resistant and diabetic. Okay? And so we're all somewhere on that journey, in the same way that we're all quietly accruing fat in our liver, maybe beyond the level we can detect it. But eventually we get the threshold where I can see it on an ultrasound scan and you get referred in. So they're probably both going on in parallel, but one of them may declare itself first. Why does that happen one way around in some people and the other way around in others? Hopefully EPOS will tell me. I'll come back and hopefully answer that one in a few years. But we don't know.
Thank you. Cheers.
Have you noticed the age profile getting younger as the years have gone on since you've been looking at this?
Yeah, absolutely.
But then the obesity rate is...
Yeah.
Childhood obesity. Yeah. So, absolutely. What we're seeing here is that fatty liver disease was unheard of in people younger than 70s a few years ago. But people are getting overweight younger, so it's the length of time that we have with fat in our liver appears to be a factor here. So if we're getting overweight younger, we'll have our 20 years with fat in our liver when we're maybe in our 40s or 50s, not when we're in our 60s and 70s. So yes, it's gently shifting downwards.
I can't believe that's the only question.
Everyone's glazed over.
You obviously
Time for another
answered.
cup of tea.
You've obviously answered all the questions. You talk.
John, can I just ask one?
Yeah, by all means.
Can I just ask about the role of stress in all of this? It's just that, obviously, as a type 2 diabetic who's one of your patients, for quite a number of years, I've noticed when I'm not working, so when I was on holiday and things such as that, my blood sugars were always actually a lot better when I wasn't stressed. And I always put that down to, obviously, things were working better and what have you. And I just wonder about the role of stress in all of this. I don't know whether it's been considered.
So, there are 2 strands of data there. Yes, it has been, but not quite in the way that you're thinking. There are 2 strands of data. We know that, for example, people working shift patterns, working stressful jobs, all those sort of things, tends to be a habit to comfort eat. Yeah? So people who, for example, work night shifts tend to be heavier than people who work day shifts because, it's 3 a.m. and the one thing you want is a Mars bar to get you to 4 a.m. So that's one side of it. The second area, and this probably speaks more to what you're talking about, there is data that the sympathetic nervous system, now the sympathetic nervous system is the one that gets you running from a saber-toothed tiger, okay, gets your heart going quicker, it gets you out the door, okay? There is evidence that the adrenaline receptors can also drive fibrosis, can drive scarring of the liver. Now that's not quite the same question, so I'm slightly dodging it because I'm not answering about diabetes, but there is certainly evidence that having that certain of the adrenaline receptors if we block them, it may slow down fibrosis. Okay. It wasn't brilliant evidence, but there is some data for that one. So yes, I suspect there's a truth in it. Some of it will be behavioural in terms of snacking and comfort eating and all those things, but there's more to it than that, and that's an oversimplification. Really interesting.
But is it not possible that when you look at the evidence that was compiled during the war, when we were never healthy, we were really the most stressful time, that our health improved?
It's a really difficult area. Yeah, that's certainly true. We were rationed, there was limits on what we were eating, and so it's very hard to tease it all apart. You could also argue, when we look at some of the things that took place in Europe during the war, there was a selection pressure there, and the fittest people came through. So it's more complex, but it's a really interesting area. The data from that time is it's interesting. It's not the most robust data because it wasn't the first thing on everyone's mind, but it is fascinating data.
You know, fibrosis, can it be reversed once it starts
Yeah,
happening?
absolutely. So up until cirrhosis, it can regress. I'm not going to say it's going to go back to completely normal, but it can certainly improve. Even at cirrhosis, the next battle, so if we've lost the first war, which is stopping the progression to cirrhosis, our next battle is to avoid hepatic decompensation, which is when people get ill, the ascites, the jaundice, and all those sort of things. So there's a good reason to lose weight and for the lifestyle changes, and hopefully for some of these medicines to be effective even then, because we still need to stop the progression of the condition. So even when we lost the first battle, we can still win the war.
I didn't get the medicines that are coming up to the market. You said that there are some new
None of the new medicines are on the market yet. They're all in trial, but there are going to be trials coming to Newcastle, so there'll be the opportunity for people to take part in if they're suitable and if they're interested.
Is that it? Well, that's excellent. Thank you very much, Quentin. I'm sure that was a very interesting talk. Quentin brought something very important to the group, though, that these medicines, you know, they have a long journey before they actually are presented to the patient. And you know, there are half a dozen medicines now undergoing trials. And what Joan said earlier is very important. That if you sign up for as a research, you want to take part in research, you invariably do better than people who don't take part in research. Now, that's not a treatment, but it's objective and it's true. So if you want to join the research register, by all means do so. The reason you do better is because the doctors look at you more frequently, they're more interested in you. You don't just have 10 minutes in their clinic once every 2 weeks or once every 3 months. You get to see them frequently, and they're doing tests and they're observing you much more carefully, and you invariably do better. So by all means, sign up for research. We have a research register which gets over the first hurdle of the ethical approval. You've already said you will take part in research. So by all means, you know, it's in the newsletter actually, a form to fill in. Now, believe it or not, I'm slightly overweight. And the doctor told me to lose weight, you know, and she said the most important thing is to lose weight very slowly. So when I went back a couple of months later, I'd actually put on weight, and you know, she was annoyed. Well, you couldn't lose it any more slowly than putting it on, could you? Anyway, no, I haven't been told to lose weight, but I know I have to. It's not rocket science. We've got some more of these books. They're in the box there. So please take one, even if you're not a NAFLD patient, and if you're a carer. There's some great dietary and lifestyle advice and some excellent graphics which Quentin had on the screen there, which I don't know where these people get them from, but they're wonderful. When I'm looking for them for the newsletter, they're not easy to find, as Fiona knows. Right, now, this talk was so good that we're going to present you with a pen. It's just a pen, but it's better than the alternative. So we'll, and Fiona will take it and shake hands. Fiona.
There you go.
Good. We'll have to Photoshop that so I look thin.
And me.
Well, I wish I was as fat as you are, Finn. Now you're going to make somebody fabulously wealthy. £250 tonight in the Numbers Club. If you're not in the Numbers Club, join. It's £1 a week, and you've got 1 million more chances of winning than you have the lottery. And that's an objective statement as well. 1 million more chances. Yes, just one number. Please, just one. We haven't got that much money.
101.
101. Joan? We'll just interrupt it.
It's Libby and James.
Oh, right. Well, I don't know if you know Libby and James. They're the people who have come to the fair. They're in that corner. They have 2 children. And the little girl always makes the presentation to Denise Robertson. So that's good. So they've won, they've been paid for years. So they're good supporters of it. We also have another raffle. I don't know where the tickets are. Who did it? Oh, here. There's a glittering array of 3 prizes here. Just the first one.
Just the first one.
The unlucky winner will pick the next one. 281. Yeah, on the buff coloured ticket, 281. Come on down, 281. Somebody must have won it. Own up.
Seen the prizes.
I've seen the prizes, I know. Come on, somebody must have bought this ticket tonight. 281. This coloured ticket? Come on. It's impossible for it not to be in this room. Right, let's have your ticket. Show us your tickets. Joan, you haven't sold... who sold the tickets? You haven't sold... You haven't sold anybody to anyone else, have you?
Well, someone's just gone out, so maybe...
Oh, who was it? Anyone know who just... Right. Well, it's too late if you're not here. We'll have to pick another one. You must stay for the draw. That's one of the rules I've just made up. And on an orange, salmon coloured ticket, 591. 591. Come on, look at that. Lucky in love and lucky in winning prizes. I'll take that off you. You can pick another one and you can then go and pick the prize. You were so lucky, aren't you? Thank you very much. Susan Hardy says 366.
Oh, it's there.
Oh, there you are. Go on then. Come on down.
There you go.
Isn't that the right colour?
Yes, that's it. Yes, that's the right colour. That peachy colour.
So you did get the right colour.
I did.
Yeah. Oh, come here. I need you to pick it. And you have to crawl under the table to get your prize. No, that's not true. It's an obstacle course, right? Thank you. And the next prize goes to... Pick your prize first, before the next person. 333 on the buff coloured ticket. 333, and that's all 3 prizes gone. No? Oh, good. Great stuff. And you get the remaining prize. Thank you. Right, that's it then, folks. Don't forget to give your car registration number to Alan Rochelle if you park without paying. You're allowed to park without paying for LIVErNORTH meetings in the multi-storey car park or the car park opposite here, but you have to give your registration number to Alan, who will tell Parking Eye that we were parked here. Okay? Any questions? Do come to the fair. That's very important. So with the fair's here, if you've got a stall, try and get here before 11:30 so you can help set up. And then we shut the doors and it's open to the members of the public, the stall holders, to shop around themselves. Okay? That's it. Thank you very much. Have a good night. Careful drive. Not a problem. That was alright. Yeah, it was excellent. No, I was going to ask you to send your talk, but it's 90% that's in the leaflet. Yeah. And I put it in the newsletter.
I think all the stuff that matters. Unless you want to bring some in.
This is about the second one I bought. The third one I bought, I keep on
If you give me a ring on that, when it's ready, where it is. Well, I'm not different. Right. So is there another one?
Did you see it? It's being recorded.
I said, oh, what did I say? Oh, dear me. One of those big old
Sense 2. We find in stage 2 when. When you're 2
I sent you rapid tickets in, you know, the rapid tickets.
And then you after the menu at Washington, that's relatively confusing. If you give me a call, then I'll put some into the and probably come in. I'm going to make you at Lumpy in Washington or something like that. You know, give me a ring or send me a text. Tell me where you're going to be. If the tour is an idea of this, we'll pick the stuff up or at some point on Thursday. Actually, you might like to know. Is she getting investigated now? Well, it might be so.
Yeah, absolutely. I was speaking to John,
We said he got
Oh, John Shaw, does he know? Does he? I know John very well.
he's got a company called LIVErNORTH.
He's a lovely lad as well. He's good rugby. He used to be a good rugby player.
He's still doing it.
Is he training with the other kids as well?
well, I said to him,
Oh, yeah. Oh, well, I've always called. And now we left part, yeah.
Well, she must have
Talking for the
oh, no, I mean everybody.
yes, well, he said. Anyhow, let's just get to bed and see.
I don't know, I know it was in the news. He's read the news again, the chief's been investigated.
No.
teaching the Bayer. She was a surname again, as you know, she was on
If you walk through them,
I'll tell you, right, I'll tell you there's a good friend of John Anderson.
All right, John.
Very well. No, he died. No, he did. Assistant chief.
Who's going to come and see you? Compensation.
You'll be retired. Look at how she is.
She's
Tall lad, really nice lad.
So I was just concerned. It should have been in.
Anyway, so I'll wait here for
Because she has a phone. So she can hear the phone.
I was worried about the same size of the actually came from
Might as well just get on with it.
see how Penny now. And there's people saying, Penny alright. Drops in there.
I've been very well. I've been
Blue stick, blue and white thing.
Oh, yeah.
It must have come out of your bag. It's a clean one. I mean, it's sort of one that I would use. No, I wouldn't use it again, but I mean, it's only one that I've been used. Right.
Stop the camera. Oh, I hate was. But I did it without the knockout drops. I just kept it away because I was interested in it.
See you, John.
Yeah, well, see you, thanks very much. See you.
Thank you, bye-bye.
You shouldn't thank you, just say it should be thank you lucky stars. You are lucky that you got a good one.
Oh, thanks anyway.
Oh no, I wanted to experience it from a scientific point of view. I wanted to see what it was like, and it was all right. But it makes you feel sick. I mean, have you had a one? Endoscopy. They're not very nice.
Just swallow it through your nose.
Yeah, just the tube. It's 8 foot long. You think, where's it gone? You're not alone, Alan. I'll just stop this.